Great. So before I step down, we were talking about ways to know when it's time to stent. And James had gone over some of the aspects of understanding detection of calcium. And the main part of what we're going to talk about now is in terms of whether the calcium has been modified and how you can figure that out before you place a stent. This is pretty operant as a principle and something we were working with in the live case that we participated in this morning. So compliance, as we know, is a measure of distensibility or stretchability of an artery or of any structure. And so the idea with compliance here is as you change your volume, do we have a change in pressure and a growth of the balloon? You can see here at a given change in pressure, we see the balloon gets bigger. This is the same concept we're applying to calcification and compliance of arteries as we talk about adequate and sufficient vessel preparation. So why does confluence of calcium matter? James alluded to this a little bit. If you think about the window of a car, the car has solid glass, and there's also a film on it. This is a nice surrogate for how we apply application of compliance to coronary arteries. With that in mind, then, as you push on a glass structure, when it's firm, it does not distend. It's not dispensable because the structure is hard. But what about now? When we're able to create fractures, especially microfractures in it, we're able to see that the film holds the window together, but you're able to cause distensibility and a change in growth or a change in distance with a change in pressure placed on it. So confluent calcium decreases overall vascular compliance. At a given pressure, the artery does not grow, and the balloon volume does not grow either. This is what leads to things like stent underexpansion and poor restoration of luminal gain in stenting procedures. When you push, we're unable to get the calcium to expand, and that ends up being an interventional problem in patients that have calcium. We know that fracturing confluent calcium dissociates its contribution to vascular compliance. It makes the arterial structure softer and allows us to access luminal gain for better interventional outcomes. Confluent calcium, as it decreases overall vascular compliance, once we're able to fracture it, we're able to see that the same change in pressure of the balloon leads to growth of volume. And this is how we're able to modify calcium to get it to expand appropriately to allow us to get high expansion stents and restoration of luminal flow. Device expansion, as we work in these cases, is a surrogate for compliance. And we applied this in the first case that we did this morning. After shockwave, we looked to see that a 1-to-1 size balloon was able to expand in two different views to show us that we've done a job in terms of whether the artery has been modified appropriately. When there's no fractures, we have low vessel compliance. This is an example of a balloon inflated at 12 atmospheres, and you can see that balloon is constricted because of the non-compliant calcium around it. Fractures, as we know, improve vessel compliance such that at the same pressure, we're now able to see that the balloon grows adequately. And we're looking at these in cases as we're trying to assess whether or not we've had an adequate change in vessel compliance to be ready to stent. But why does the volume of calcium matter? Thinking about this, calcium takes up space behind the stent. And as we go, especially with eccentric calcium, as James reviewed earlier, as we go to blow up a balloon, the compliant part of the vessel is away from the calcium. And this is where we get into trouble with perforations because the lower portion here, which is not yet modified, is unable to accommodate growth in volume. And we're really relying on the adventitial structure away from the calcium to be able to grow, and this is what leads to misshapen or D-shaped or underexpanded or malformed stents. So what we're hoping to do with things like atherectomy is reduce the volume of the calcium, to have this material take up less space to hopefully restore the geometry of the arterial lumen. Additional to that, we're then able to think about applying other technologies such as shockwave, which fracture the calcium and allow us to get further luminal gain. The mechanism of action shown here, first to reduce volume and then to change the compliance with shockwave, really forms the basis of a lot of the hybrid strategies we have, such as rotational atherectomy followed by IVL. We're hoping to restore the luminal geometry and change the compliance in a way which allows our stents to expand completely. And so what tools do we have to assess modification? We can think about angiography. Does the arterial lumen look better on angiography after modification? We can think about intravascular imaging. And as shown, you can look at whether or not the device expands well, as is illustrated in Culm's case and in the case that I participated in this morning. So really, I think using all three of these modalities is required to help us make a decision of, am I ready to stent after assessment and modification of calcium? As spoken about earlier, we want to restore physiology, which means improve flow, and this is commensurate with getting adequate luminal gain. And so assessing luminal gain in terms of being able to completely restore the size and shape of the lumen is done by modifying calcium and then stenting to avoid recoil. However, there may be partial restoration. This is where we have stent underexpansion, with, at least in our practices, a lot of the reason why people come back with failed stents, or no change in the lumen whatsoever. So why is there potentially suboptimal restoration of luminal area? There's several things that can contribute to this. First is inadequate modification, not adequately changing the compliance of the calcium, not adequately debulking the calcium. Potentially devices are undersized. I think there's been a lot of attention spoken this morning about the use of intravascular imaging to assist us with sizing, not just in terms of stents, but also in terms of sizing and the vessel preparation modalities we use to modify calcium and determine if the calcium is compliant enough to be able to stent. And then the problem with recoil, which can happen even when we stent a vessel, especially in heavily calcified arteries. And there is a role for high radial strength stents in some of these cases. Intravascular imaging and balloon expansion are things that we use in tandem. They're used together in these cases. We want to determine what the size of the artery is, so we're applying one-to-one size devices, one-to-one size balloons to look at expansion. And we look at this in a way where we often will check in two orthogonal views, especially with eccentric calcium, to make sure that the balloon is expanding appropriately before stenting. Luminal gain is only a single static surrogate for physiologic change. We really want to be able to see if fractures are present, because this helps us to understand whether the calcium has been modified substantially. Intravascular imaging can be used to detect fractures. I showed you this in the case we did this morning. With the HD IVUS, we were able to see that the IVL treatment fractured the calcium substantially, especially in the mid to distal segment. We did not have enough calcium fracture or enough growth in the balloon proximally, so we used a second IVL balloon. The case we did this morning really shows the operation of how to use balloon expansion and imaging in tandem to be able to determine whether the vessel is appropriately modified. As we know, IVUS is lower resolution. It does not show fractures as well as OCT, but it does have a greater depth of penetration. OCT is higher resolution, but penetrates less deep into the wall, and a lot of times you can use one or the other device in these cases. It's rare that we use both, but you need to be certain about the positives and the negatives of each modality as you're trying to assess calcium and assess its modification. So thinking about IVUS and IVUS calcium detection and characterization, obviously disruption of surface continuity and fracture is dependent on the resolution. Higher resolution IVUS systems are able to show you fracture better than lower resolution ones, but not quite as good as OCT. When you have fracture, you're able to see new penetration beyond the calcium into the vessel wall. You can start to pick up depth of the structure as you fracture calcium, and you can start to see beyond the calcified segments. That's commensurate with fractures and changing the penetration with the ultrasound waves. We also tend to see new reverberations between the smooth calcium surface and the transducer. This is another signature that you've done adequate or done some calcium modification. So inference is about calcium thickness. If you have a smooth border with reverberation, this tends to suggest that the calcium is relatively thin, often less than 0.5 millimeters, with only about 50% specificity. As we know with IVUS, we can't see too deep behind the calcium, but we can start to use these features to let us know if it's thick or thin. And this is potentially, as Carlos highlighted, one of the really valuable bits of CT planning, because with CT you can get a very clear idea of thickness in a way which is different than IVUS itself. Thinking about whether there's no reverberations and if the border of the IVUS is irregular, shown here, it often suggests with 75% specificity that the calcium is relatively thick. Patterns of modification are shown here. You can see fractured calcium, and when you fracture the calcium, you're able to see past the fractures with gain of depth of resolution of the IVUS into the vessel wall. So see the fractures and being able to see these tissue structures afterwards means there's been adequate modification. Get better penetration of the ultrasound. This is an example of how atherectomy reduces calcium volume, and after atherectomy you'll often see that you get these reverberations, which are commensurate with having modification of the calcified tissue. New reverberation means that you're actually able to get a change in the structure of the calcium. With atherectomy, you can see pre and post OA here. You can see these new reverberations are a result of the modification that was done previously. Detecting modification can also be done on the longitudinal view. James showed us how to use the longitudinal view to assess calcium, whether it's eccentric or concentric. And you can see here, depending upon which segment of the longitudinal view we're looking at, if you turn it to this spot, you can see that there is gain of reverberations in the area which is where the calcium's been modified. So after modification in the long view, you can detect that both in the cross-sectional view and the long view of your IVUS run. OCT is similarly helpful for looking at calcium modification. You can see fracture and intimal disruption quite well. Fractures here, and oftentimes you can see fractures which go relatively deep into the calcium. However, because of the limited depth penetration of OCT, it can be hard to actually tell how deep those fractures are, and I'll show you some examples of that next. Calcific nodules in this example show really quite clearly the limited depth of penetration of OCT. In calcified nodules, we really have a hard time seeing behind the structure of these. And we often know by micro-CT and other modalities such as standard CT that these things often have a large foundational base, which is difficult to modify. And so being able to see deep into the base of a nodule is something that we're limited in with in-case intravascular imaging at this point. After IVL, you do see a little bit of a change, but the depth of penetration does not pick up very much. And as we know, IVL creates microfractures, which are often below the resolution of OCT. This shows the calcific nodule after rotational atherectomy and IVL, and again, you don't see much change in the depth of penetration compared to what you might expect after this modification. So, as we spoke about, OCT has high specificity but low sensitivity for detecting fractures. And so if you see them, you know you're there, but because you don't see them doesn't mean that they're not necessarily present. And I think this is especially important after modification with IVL, where the fractures are below the resolution of OCT. So you can see here that there's about a 57% sensitivity that's been shown for OCT for detecting fractures. However, it dramatically underestimates the depth of fracture compared to what we see on micro-CT or potentially on histologic samples. And so you need to be a little bit more measured with OCT. If you see fractures, great. If you don't see them, it doesn't mean that the vessel is not compliant enough. And that's where our use of one-to-one sized NC balloons to test balloon expansion can be an adjunctive tool to see if it's time to stent. There's poor correlation with fracture depth with OCT, as I told you earlier, and you can see that in a graphical way where often depth measured by histology does not necessarily correlate quite well with what we see on the OCT. OCT's limited depth of penetration is shown here, a micro-CT compared to the OCT itself, and this is after IVL. And you can see that fractures are detected in this segment, which are not necessarily shown on the OCT. So we also have trouble either with OCT or with IVUS with wire artifact, potentially obscuring spots. You can't see behind the wire in the OCT here, but you see quite a large fracture on the micro-CT. And so these are things you need to be mindful of when you're using these tools to assess whether you're ready to stent. Some of the blind spots with intravascular imaging are absence of fractures does not indicate that it's not time to stent in terms of compliance. And as we talked about, that's where the one-to-one balloon sizing can be helpful. This was shown quite nicely in this Disrupt CAD study, where even in cases where observable fractures weren't present, the stents still expanded similar to cases where fractures were present. And so the premise here is that because IVL-associated fractures are below the detection of resolution of OCT, in cases where fractures weren't seen after intravascular lithotripsy, the stent still expanded quite well. And so there are some blind spots with this, as aforementioned. And so seeing fractures is great if you see them, but absence does not necessarily mean that you don't have adequate change in compliance. And so how does this translate into everyday practice? As discussed earlier, calcium is heterogeneous. We have eccentric and concentric, and they potentially need different modalities and different tools to assess whether or not it's time to stent. And there's really imperfect sensitivity of any one modality, OCT, IVUS, or balloon expansion. And so we want to use these tools together as adjuncts to be able to see whether or not it's time to stent the vessel. So how can a balloon help? You can see here, as we saw in the case this morning, that the balloon is hugging this eccentric calcium, not expanding well. If you see this, you have to be worried that it's not time to stent because the lesion has not been appropriately modified. And so oftentimes we'll take this angiographic view in 90 degrees of each other to see that we've got good expansion in two orthogonal views. And so thinking about how this translates into practice, really, we want to be able to use all these tools to be able to make sure that we're assessing compliance in a manner that we don't get stent under expansion. So a framework for this is we want to be able to assess the vessel, identify the calcium presence, and specifically the type of it, because eccentric calcium versus concentric calcium may need different tools to be able to treat them. And also vessel sizing is an important piece of this, because if you take a 2.5 balloon in the proximal LED and it expands well, when it's a 3.5 artery, you end up fooling yourself, and that's where we can get into trouble. So by way of summary, the assessment is made first, potentially fluoroscopically. If we have the ability to have a CT ahead of time, we've seen the value of that today. And then once we identify it, we want to be able to modify it in a manner that we can determine that the calcium is compliant in a way that we're going to get good stent expansion, using intravascular imaging with IVUS or OCT, and with good balloon expansion to be able to have one-to-one size devices expand appropriately allows us to know that it's time to stent. So by way of summary, calcium confluence and volume determine a requirement for calcium modification. Fracture of confluent calcium dissociates its contribution to vascular compliance and allows the artery to expand. Balloon expansion is a good surrogate for vessel compliance, and we have imperfect sensitivity of any one modality to detect modification, and we need to integrate multiple things when deciding when it's time to stent. Thanks very much for the invitation to be here.